My name is Amy Stevens. I'm the General Manager for Provider Innovation at Innovaccer. We are so excited to have you joining us today for our Xccelerate podcast. And what I'm really excited about is introducing you to our speaker. I've been really anxious to have this discussion with him so that we can share it with you. Today I'm joined by Sam Hiatt. He's the Director of Medicare Program Operations for Community Care of North Carolina. Welcome, Sam.
Great to be here.
Well, we're going to actually start from the very top, not all the way back to your birth story, but we're going to start with your professional story. We know that, or they're about to find out, that you're a clinician by training, but have since then moved into a management role, still very much sitting in your clinical roots. You want to tell us a little bit about that?
Yeah, absolutely. So I'm a pharmacist by trade, and definitely still keep in touch with that as well. I went to Butler University in Indiana, where I'm from, and ended up relocating to North Carolina, where I've been ever since graduating. While at Butler, I got a business minor as well, and so my passion for business and operations definitely started early. I spent about 16 years in the community setting, held various roles there, both in the store as well as in management, and decided a little bit after COVID started to make a career switch. And so ended up moving over to a startup ACO, or accountable care organization. Started in clinic there, working with Medicare patients, transitioned to a director role there, where I partnered with two networks that we supported, one of which was CCNC or CCPN, which is our provider network. And unfortunately, the ACO did not survive, which is not uncommon in that space.
Not uncommon, and it's good that we have people out there trying different models.
Absolutely. And I learned a lot through that process as well, and met a lot of great people. And while I was with the ACO, I really meshed with the mission of CCNC. So they're dedicated to supporting primary care, independent primary care in North Carolina, and the role that plays in access to care for patients and the quality of care that we can deliver to patients is just so important.
Yeah, especially with the growing amount of employed physicians, we know that there's also still a tremendous need for independent doctors who are spread in a lot of communities that may be underserved.
Oh, absolutely. So yeah, just that access component, but also the cost effectiveness of care is so critical, and we really see a return on investment when it comes to independent community care. So fortunately, through that transition of the ACO closing, CCNC had reached out to me and expressed interest in, first off, supporting the patients that the ACO was supporting, which definitely meant a lot to me, that they didn't want those patients and those practices losing the support that they had.
That would have been a big disruption.
Oh, absolutely. And these patients, we had built a lot of relationships with them. They had come to really depend on us to help bridge that gap between their PCP and their healthcare goals. And so started in 2024, October, supporting those patients very quickly, started looking at the future.
So that means you went through COVID all the way as a community clinician?
Not all the way. No. I was in clinic for a while, and then and then in management. So I was able to avoid some of it, but I spent a lot of that time behind the counter. I gave a lot of COVID vaccines. It was front lines, and definitely a changing time in the healthcare landscape. I think we've learned a lot of lessons through that, and hopefully we can continue to learn lessons moving forward as well. Absolutely. Yeah, I don't miss it either by any means.
I can understand. You did that part of your career.
I did that part of my career.
So you essentially ended up in like a startup then, as I understand it, within CCNC.
Absolutely. So CCNC historically has really focused on the Medicaid population in North Carolina. And they definitely saw the need for that care management support in the Medicare space. And how can we bring it in-house? How can we make sure that moving forward we can have a lot of control over this, and make sure that there's a longitudinal component. We don't have to worry about a partnership or that care going away or dissolving, unfortunately. And there's a lot of opportunity in the Medicare space as well from a business standpoint.
Okay, so tell us about that, because people are anxious to hear about that.
Yeah, so we operate under Advanced Primary Care Management. It's a new model, also referred to as APCM, much easier to say. Sure. That launched January 1st of 2025. It was released in the Federal Register, so as soon as it was released, we started doing our research and identifying how we could incorporate this new model into our model of care. I had worked under the chronic care management, which was kind of the predecessor to APCM. But there's a big shift in the focus, which I actually really agree with a lot of the changes that were made in the model. So under the CCM model, it's a time-based billing model. So you bill in time blocks based off the amount of time you spend talking to patients or appropriate documentation, et cetera. Whereas under APCM, it shifts to a services-based model. So there's a list or a suite of services that need to be provided to the patient and accessible to the patient at any point in time to be able to bill for it, but it starts generating a per member per month billing cycle.
And tell us a little bit about why that services versus time is so different and in your mind an impressive path forward.
Oh, absolutely. So I really think it aligns with the vision and the goals of value-based care. So what this allows is a lot more flexibility when it comes to providing the right amount of care to the right patients at the right time, where we can dedicate a lot of time to a patient that needs that amount of time, a patient coming out of the hospital post-utilization. We can spend a good amount of time. We can dedicate a lot of resources, a lot of clinician resources to that patient to make sure their transition's successful. They're extremely vulnerable coming out of the hospital. We know those 30-day readmission rates are so high. So doing everything that we can do and dedicating a lot of time and energy to making sure that they are staying in the ambulatory care setting, they're not going back into the hospital. Whereas a patient that's generally stable, but they have some conditions that we want to make sure stay stable.
Yes.
We can
no rising risk.
No rising risk. We do not want that. We can set a monitoring plan in place and just have periodic touch points with that patient, or maybe we call them for 5 minutes and check on some blood pressures.
So opposed to this time block that you
Absolutely.
had to.
Yeah, there was a real necessity to contacting every single patient for a specified amount of time every single month, regardless of whether they need it or not. And that caused patient abrasion, where a patient didn't feel like they needed it, and they may not have at that point in time. It caused provider abrasion as well from a documentation standpoint. There's also a lot of administrative burden that comes with time-based billing and the documentation required. So it removed a lot of the barriers that prevented CCM from being widely adopted. I think the last data I saw showed about 4% of Medicare patients ever had a CCM claim billed. Wow. We know the outcomes of the program were good. We saw a reduction in overall cost of care. We saw reduced utilization rates. Unfortunately, we just didn't have a lot of patients that were participating because it was so burdensome from an administrative standpoint.
Yeah, that makes sense. Well, I love how you're talking about how the economic model is shifting to meet more of what you believe is helpful for the care of the patients. Yeah. Talk to us a little bit about things that you may be doing in the program that are helping to bend the cost curve as you're improving the quality of care. You're an operations person too.
I am.
So there's a lot of people listening who are going to say, okay, how do you actually do this, Sam?
Oh, absolutely. Well, it's a tough question to answer, and I come from the ACO space where that's the whole goal is to really bend that cost curve. And so we've taken a few different approaches. I don't think it's a one-size-fits-all solution. We provide longitudinal management to our enrolled patient population, making sure that we're focused on those rising risk patients, but the patients that are already sick as well, and making sure that we're maximizing their outcomes. And then we focus on post-utilization quite a bit as well. Our model is designed around, post-ED discharge, making sure that patients are contacted. Wasn't it appropriate? It's a lot of education. Was it a truly appropriate ED utilization event? If not, what education points can we deliver to make sure that the patient understands where to go next time that event occurs? On an inpatient admission, that tends to be a little bit more serious. So those patients, we outreach within 48 hours. We continue to follow that patient for a full month post follow-up. So every single week, sometimes multiple times a week, we're outreaching to that patient based off their level of risk and their risk of readmission, and making sure that they have everything they need from a care coordination standpoint. Are they getting back to their PCP? We know that's the number one driver of readmission prevention. But then post-PCP visit, are they following the plan of care for the hospital and for the PCP? Are they following through on the things they need to do?
What might be in their way?
Absolutely, removing barriers. Which brings me to, I think, the real core of our program, which is the multidisciplinary care team.
Yeah, tell us a little bit about this, because everybody's trying to figure out the magic formula in order to have the right types of services and care, and to also recognize oftentimes the expense that goes with some, highly sought after clinical teams.
Yes, yeah. If resources weren't a problem, it'd be wonderful for
Right,
all of us.
that's right.
But
We'd all get our own private nurse.
exactly, that is not the case.
Or pharmacist,
Or
right?
pharmacist, yes. So we use a multidisciplinary care team, and the care team itself is a cohesive unit. So it operates as a single unit. It consists of a clinical pharmacist, a nurse, and 4 medical assistants. We call them personal healthcare navigators. Okay. The design of the program, they each have their specific roles. But we use the MAs or the personal healthcare navigators as kind of the backbone of the team. So each practice and each patient is assigned a specific personal healthcare navigator. We found that this builds that trust over time when you're looking at longitudinal care. When they're outreaching to us, they're talking to the same person each time. When we're talking to them, unless it's the nurse or the pharmacist, they're talking to that same person each time.
You're sort of grounded in the history of the patient.
Yeah, they get to know the patient, they get to know their dog's name,
Yeah.
their kid's name.
But it makes a huge difference if you're looking
does.
for that engagement.
It does.
Right?
No, it's so critical, and I read the notes, I review the notes, and I know just about every dog in North Carolina at this point in time.
And which kind of dog food they
And which
like,
kind of
right?
dog food they like, yep, absolutely. But we found that through these conversations, we can also identify where we have opportunity to support the patient. So do they have a social support network in place? Do they have family living around them? Do they have hobbies that they like to do? Are they ambulatory? Do they get around? Do they drive? Do I need to worry about transportation to their appointments? So we actually gather a lot of information just getting to know the patient when we first meet them and continuing that relationship over time. And of course, it takes time to build trust so a patient opens up around how you can support them as well. So
tell me a little bit about how you think about risk and risk stratification, because I believe you've taken both a data-centric approach, sort of, I'll call it pure numbers, right? But very deeply rooted in data. But you're also overlaying clinical insights and then a fairly frequent,
cadence.
Yeah, exactly.
Yeah, absolutely. So I've used many algorithms over the years for risk stratification, and while they are definitely beneficial when it comes to looking at your overall population and their risk, what we have found is there are some inherent challenges based off of your data sources. Under APCM, we have some challenges when it comes to data sources, but also just the retrospective nature of the prospective risk scores. And so what we use that as a backbone or a data point of our risk stratification of our population. But after every initial visit with the patient, typically the pharmacist, but one of the clinicians will take a clinical look at the patient based off of that risk score, the clinical data points that we're looking at and we've aggregated into the Innovaccer platform, as well as the conversation that the PHN had with the patient, and come up with what we call a clinical lead risk score.
So clinical lead risk score. So tell us about that.
Yeah, so the clinical lead risk score takes all those factors into account, and it really determines the intensity, the frequency, and the type of follow-up that the patient will receive. So is this a patient that has a lot of medication problems that the pharmacist needs to be extremely active with and resolving, or we need to deprescribe medications, which we really focus on in the Medicare population quite a bit. Or
those bags of medicine.
Those bags of medicine that they hold up in front of the screen when you're talking to them, it's a nightmare. As a pharmacist, I've seen it all too many times.
And their caregivers also say that too. Right?
Yes, absolutely. But they take everything. They never miss a dose. Or is it a patient that needs more nursing support where it's more medical needs? Or is it a patient that just has a lot of barriers to care where our PHNs can step in and help them with care coordination or transportation or removing SDOH barriers, which are so prevalent and common in our population?
In terms of social determinants, because we're kind of going there, are you doing anything specific to identify possible needs, that are more community-based, socially based, and how are you addressing those? Yeah,
so we have some indicators. We use the SVI, although that's not the most precise score in the world. So a lot of it comes from our screenings and our conversations with patients. So we do on a regular cadence, every initial visit, at least every 6 months, if not more often, any utilization event, we complete an SDOH screening. So we're making sure we're getting a good handle on what barriers the patient may have. If we identify anything positive on there, it's our job to resolve that. And to be honest, we're actually pretty good at it. We work very closely with our practices who are very much based in their community. Another benefit of independent primary care, they're a cornerstone of their communities. We work with national resources, we work with the payer resources, but it is our goal to solve any barrier that patient has to their care. And that care team will work together as a whole to make sure that barrier is resolved. What we found is unless we can solve that baseline barrier to the patient, we really can't be effective clinically. So I can prescribe the best medication therapy in the world. If the patient can't afford it, it doesn't solve any problems.
Right. And it spirals from there,
spirals,
right?
Absolutely.
In ways that hopefully are avoidable when you're able to, in fact, spot that and be able to address it. Well, I know you've talked to me about the amount of time you spend working with data, and over the years, how that's changed and how technology and analytics have become far more modern. Do you want to talk a little bit about sort of your daily life with data?
Oh, I spend a lot of my day working with data for sure. So data is so important, especially acting as a care management organization. We want to aggregate as much data as possible to really get a full clinical picture of the patient. And so we utilize Innovaccer to aggregate clinical data feeds where available. We can get claims feeds. We utilize real-time ADT feeds. We utilize lab feeds. And all that will aggregate into the system and allow our clinicians to take a kind of bird's eye view of all these different factors when it comes to that patient's risk, outcomes, and all the other factors that we need to take into account when it comes to their patient care. And so, me working with all those different data sources and making sure data integrity is good, making sure the connections are good, setting up the connections. We're in a startup mode, so we're still setting up connections. It's been a definite learning curve for me, but I've really enjoyed it. I've learned a lot, and working with the team at Innovaccer has definitely taught me a lot as well. I didn't know what an SFTP was until I had set up about 6 of them, so now I'm very familiar with SFTPs.
Tech, right?
I can talk tech. I still can't talk engineer, but I can
That's
talk
okay.
tech.
That's
yes.
okay. Making progress.
Making progress, for sure. But it is so critical to everything that we do, both from a care management perspective, but also from a practice perspective. When you think about the efficiencies that are required in the modern healthcare system, like we talked about earlier, resources, they're not infinite. And right now they're very, very finite.
Yes.
So you have to be extremely efficient and effective with your resources, and data allows you to implement some of those strategies to do that.
And when you think about the data that sits inside your team and the broader CCNC, talk a little bit about how that transfers out to those independent practices. How are they seeing, support changes, the ability to engage differently? Yeah,
absolutely. So, we will share this data with the practices. So all of our documentation, we call the PCP the captain of the ship. We operate under their supervision. So they are, at the end of the day, they are the PCP for this patient. We want to make sure they're fully informed about their patient's care. They are their patient. We're here to support them. And so making sure that they understand everything that we're working on with the patient, make sure that they understand any recommendations that we have for the patient, any open care gaps that are available to be closed for the patient, where there may be some coding requirements for the patient as well. Getting that in front of them is so important, and so working with the practices so they have full visibility on all those different aspects that are so critical when it comes to reimbursement, when it comes to the clinical outcomes. It is just so key to everything that we're doing in healthcare right now, and data is required for all of those.
Yeah, for sure. Now, one of the things that you talked about was getting access to clinical data, right? And you've got 50, 60 probably EMRs spread throughout the community. We have, Bob's uncle's cousin EMR, as well as the more main stage ones. But there was some things that you've done to try and get people moved to some of the, I'll call it more typical EMRs, as a way to create standardization, efficiency, the ability to track a little better. Even though you can still get that data, it's just caused, inefficiencies, right? What did you do to help encourage that migration?
Yeah, and I cannot take credit for this. So first and foremost, this was not my idea.
Listeners know that it's somebody else.
This was not me. But this actually started when I was at the ACO and I saw this and I just thought it was such a good idea. So they built out an incentive program at CCNC to incentivize providers and practices. Again, we're working with independent primary care providers across the
Who
state.
are often, 2-3 people in an office, right?
Absolutely, and we're talking homegrown EMRs from 20 years ago that they've been working on ever since.
But are highly tailored for what they want.
Highly tailored for what they want, and they are very used to it.
Yes.
But unfortunately, when you look at the analytics, when you look at the code suggestions, when you look at the quality care gap notifications, and just all the other aspects that are a requirement of patient care in today's age, they're not there. And so, and plus just the data integration. So how can we also extract the data as their network to help support them in closing care gaps and submitting supplemental files, et cetera? And when you can't integrate with that EMR, it's very difficult. And so they built a scholarship program or incentive program for practices to help support them to transition. They vetted different EMRs, so they made a selection of kind of their top 3 EMRs that had good integration platforms, that were robust when it came to the clinical aspects, but also the administrative aspects, the billing aspects. And so they had this tailored list, and the practices could opt in to switch to one of these new EMRs, and they would get a financial incentive to help support them through that transition, because of course it's not cheap to transition either.
No. Yeah. It's both the true dollars and then of course the switching costs.
The switching costs, absolutely.
That's just significant. Yeah. Well, I bet you might get some phone calls from some of our listeners about that program to understand how it worked.
Absolutely.
If you were to think about how you spend your day and managing this program, are there certain things you find yourself gravitating to daily? Like, these are my core tools. This is sort of what I need to run this program effectively.
Well, I mean, Innovaccer is our care management platform. I'm in there all day, every day, whether it's reviewing notes, and this is where I put my pharmacist hat back on and review notes from a clinical aspect, whether it's looking at the population as a whole and looking at our engagement rates or looking at our enrollment rates. Looking at utilization rates, making sure we're making an impact on overall utilization metrics for our enrolled and our total population, readmission rates, et cetera. So that's really the tool I use most often when it comes to managing our patient populations. I don't have access to every EMR in our network, nor do I want to have access to every EMR in our network.
Careful what you ask for.
No, thank you. So it's a good tool for me to use to get that bird's eye view of what's going on, but then also be able to dig into the details and see what my teams are doing day in and day out. It allows me to do some operational monitoring. What's working, what's not working. Like I said, we launched in April. We're still iterating. We're still seeing and getting feedback from the teams on where we need to make adjustments and changes, where we have efficiencies that we can build into the program. So, we've implemented strategies. So how can we automate chart preps? How can we target the right patient populations, and how can we utilize the tools that are available to make us more efficient so we can spend more time with the patients, which is the most effective use of our time.
And I think you've got an eye towards moving from automation to literally AI as you're going forward. Yeah,
so it's definitely something we're looking at. AI is definitely the buzzword right now, but some of the tools that I've seen, whether it's the Sarah for Care Management and helping my teams document, or even some of the AI agents that are available. I know that's a new feature. These are things that we're looking at.
Like with callbacks, for
Absolutely.
instance, after discharge.
Yeah, to really engage the patients, but reduce the time on the non-productive tasks. And that's really where I want my teams focused, is how can we best use their time to drive the best outcome for the patient? And that's a challenge. So we're going to use any and every tool available to get that done.
Well, listeners, we're on the last question, so we're going to make it count. This is one I love to ask people, and that is, if you had a do-over card as you think back and how you've gotten here, and it can be longitudinal or it can be recent within this program, is there something you would love to share with people to say, like, here's a lesson I learned? Let me give you a shortcut.
Yeah. Well, 2 things come to mind, and that's a tough question.
Oh, you get 2 do-over cards.
I get 2 do-over cards.
You're
I don't know. Yeah, I'm really pushing my luck here.
You're an excellent.
Yeah. But one is making the transition to value-based care earlier. I always believed in it, and it always aligned. I remember telling patients when I'd be vaccinating them, I'd much rather prevent you from getting this disease than have to treat this disease, and that's what value-based care is all about.
And that's what patients want, too.
That's what they want.
And clinicians, I love that you say that's what, as a clinician, you've always wanted anyway.
Yeah, absolutely. And the other one, and this one I think about a lot recently, in this role especially, but the role of mentors, and really, I've had some great mentors throughout the years. I think of Steve Knorr and Dave Grapey at the ACO, and Steve I still work with regularly, and I'd just be in conversations just listening to them and just absorbing their knowledge over time, and they were so open to giving feedback and sharing their knowledge with me. And they're just two of many mentors I've had over the years. But then how can I be a mentor to others and really take the time to reach out to different people and ask what they're interested in. Sometimes we get so lost in the day-to-day operations.
Yeah, you have to come up in altitude.
And see, hey, where are your interests at and how can I support you in that interest? And so, definitely over the past couple of years, that's been something I've been working on. I can't say I perfected it, but spending more time trying to be a mentor to my team members as well as anyone else that I work with.
That's a really good call for us because all of us know our teams are under tremendous stress as the world is changing in ways we can't even predict. And you look around and you realize everyone on our team is in some way affected by that. And they may not always reach out voluntarily. And so to look around and say, who needs to be in apprentice mode so that I can be there for them? And that really is at every level of the organization. It can get lonely in certain jobs where people are looking for feedback as well.
No, I had one supervisor tell me that, when I moved into management, I don't have patients anymore, but now my teams are my patients.
Yeah.
So really, like my teams spend the first 5-10 minutes of their call getting to know the patient, spend the first 5-10 minutes of our touch base getting to know them. What are they, what's going on in their personal life? What are they interested in, and how can I support them? And really taking that patient first approach, which we all try to take, and just making sure that they're achieving their best outcomes as well.
Well, on behalf of our listeners who I know have enjoyed this time with you, I want to say thank you, Sam. Thank you for sharing your knowledge. Thank you for giving us some intriguing ideas to think about as we operate our own programs. And on behalf of Innovaccer, I want to thank you for being here with this issue of the Xccelerator podcast.